Pediatric Integumentary Disorders encompass a range of skin conditions affecting children, including eczema, psoriasis, and impetigo. These disorders can impact a child's quality of life, requiring careful diagnosis and management. Treatment often involves topical medications, lifestyle adjustments, and sometimes systemic therapies to alleviate symptoms and prevent complications. We are discussing the Chapter 31 of Wong's Essentials of Pediatric Nursing, Integumentary Dysfunctions. Pediatric skin infections can be categorized into bacterial, fungal, and viral types. Bacterial infections, such as impetigo, are common and often caused by Staphylococcus or Streptococcus bacteria. Fungal infections like ringworm result from dermatophytes. Viral infections, including Molluscum contagiosum, are caused by viruses like pox virus. Each type requires specific diagnosis and treatment. Bacterial skin infections in children are primarily caused by Staphylococcus and Streptococcus. These infections can lead to conditions like impetigo, cellulitis, and abscesses. Prompt diagnosis and treatment are crucial to prevent complications. Antibiotics are typically used, but resistance, such as methicillin-resistant Staphylococcus aureus, poses challenges. Emphasizing hygiene and cleanliness is essential to control the spread, especially in vulnerable populations. The skin hosts normal flora, including Staphylococcus and Streptococcus. Infection risk hinges on skin integrity, organism toxicity, and host immunity. Children with immunodeficiency or on immunosuppressants are particularly susceptible. Staphylococcus infections are challenging due to abscess formation. Methicillin-resistant Staphylococcus aureus peaked in 2007. Hand hygiene and cleanliness are crucial, especially for infants and children. Furuncles and carbuncles involve bacterial infection of hair follicles, forming boils or clusters. Treatment includes incision, drainage, antibiotics, and warm compresses, though healing is slow and may scar. Folliculitis, a milder inflammation, is treated with topical antibiotics and chlorhexidine cleansing, typically healing without scarring. Meticulous skincare is crucial for all conditions. Pyoderma involves deeper dermal infections requiring soap and water cleansing, topical antiseptics, and mupirocin. Cellulitis affects subcutaneous tissues needing antibiotics and possible hospitalization to prevent gangrene. Impetigo presents with honey-colored crusts, treated with topical creams, systemic antibiotics, and good hygiene practices. Nurses can help to manage by emphasizing hand hygiene and avoid touching lesions to prevent infection spread. Use separate personal items and change linens daily. Consider chlorine baths and mupirocin for methicillin-resistant Staphylococcus aureus prevention. Avoid squeezing lesions. Clean styes gently. Mild cellulitis can be managed at home, but severe cases may require hospitalization for intravenous antibiotics. Now we'll discuss viral skin infections in children in general. These are among the most common childhood conditions and are usually caused by viruses like pox viruses, enteroviruses, or measles and rubella viruses. Children often present with rashes, mild fever, and itching. The main goals of management are to relieve discomfort, prevent secondary infection, and promote healing. Nursing care focuses on maintaining good hygiene, providing skin comfort measures, ensuring hydration, and preventing spread to others. Vaccination plays a vital role in prevention, so educating parents about immunization and infection control practices is essential. Viruses are intracellular parasites composed of DNA or RNA within a protein shell. They rely on host cells for reproduction and metabolism. Once inside, they shed their shell, directing the host cell to produce more viruses. This process can lead to inflammation and blisters, as seen in herpes or abnormal cell growth like warts. Verruca, or warts, are typically well-circumscribed gray or brown papules with a rough texture, often found on fingers, hands, face, and soles. They can be single or multiple and are usually asymptomatic. Management includes local destructive therapy, surgical removal, electrocautery, curettage, and cryotherapy. Emphasize hand hygiene, avoid scratching, and address cosmetic concerns. Verruca plantaris or plantar warts appear on the foot sole, often flat due to pressure, and may have a hyperkeratosis collar. Management includes applying caustic solutions, using foam insoles, and soaking. Assess pain and walking impact, educate on foot hygiene, discourage barefoot walking, and support treatments like salicylic acid or cryotherapy. Varicella zoster virus, responsible for chickenpox, targets the posterior root ganglia and skin, causing vesicular eruptions along nerve paths. Management includes analgesics, drying lotions, and antivirals like acyclovir. For ophthalmic cases, corticosteroids are used. Vaccinations advised for those over 50. Emphasize infection control, lesion assessment, and supportive care. Herpes simplex virus presents as grouped, burning vesicles on mucocutaneous junctions, healing in 8 to 10 days. Management includes Burrow solution compresses, oral antivirals like acyclovir for initial infections, and valacyclovir for episodic treatment, especially in immunocompromised patients. Emphasize infection control, symptom management, and education on triggers to prevent transmission. Molluscum contagiosum presents as flesh-colored papules with a central plug, often on the trunk, face, and extremities. It's usually asymptomatic but can spread through direct contact, including sexual transmission. Management focuses on cosmetic treatment, discomfort alleviation, and infection prevention using agents like tretinoin gel or imiquimod cream. Emphasize hand hygiene and avoid scratching or sharing personal items. Next, we'll discuss fungal skin infections, commonly known as tinea or ringworm. These are caused by dermatophyte fungi that live on the skin, hair, and nails. Children often get these infections through contact with infected people, animals, or contaminated objects. The typical sign is a circular, red, scaly patch that may itch or peel. Treatment includes topical or oral antifungal medications, keeping the area clean and dry, and preventing spread by avoiding shared personal items. As nurses, our role is to educate families about hygiene, medication adherence, and prevention strategies to reduce reinfection and transmission. Fungal infections, or dermatophytoses, are superficial infections affecting skin, hair, and nails caused by filamentous fungi. Known as Tinea, they are named by location, like Tinea capitis for scalp. These infections spread via contact with infected individuals or animals. Diagnosis involves microscopic examination of lesion scrapings, revealing characteristic scaling. Tinea capitis affects the scalp, causing scaly patches or alopecia. While often asymptomatic, severe cases can lead to carions, which are boggy, encrusted lesions. Management includes oral grisafulvin or terbinafine with ketoconazole for difficult cases. Selenium sulfide shampoos used twice weekly help reduce infection. Carions may require grisafulvin and oral corticosteroids for effective treatment. Tinea corporis presents as round or oval, erythematous scaling patches that spread peripherally and clear centrally, sometimes involving nails. Diagnosis involves direct microscopic examination of scales. Management includes oral grisafulvin and local application of antifungals like tolnaftite or miconazole. Avoid high-potency steroid antifungals due to potential for further infection and side effects. Tinea pedis, commonly known as athlete's foot, affects intertriginous areas between toes and the plantar surface. Lesions may include maceration, fissuring, and vesicles, often causing pruritus. Diagnosis involves microscopic examination of scrapings. Management includes topical antifungals like terbinafine and cyclopirox, or oral treatments for severe cases. Burrow solution compresses can also be beneficial. Tinea cruris, commonly known as jock itch, presents with pruritic lesions localized to the medial proximal thigh and crural fold, potentially involving the scrotum in males. Diagnosis mirrors that of tinea corporis. Management includes twice daily applications of tolnaftate liquid, terbinafine, clotrimazole, or cyclopirox for 2 to 4 weeks. Candidiasis thrives in moist areas, presenting with inflamed pruritic regions, white exudate, and bleeding. Diagnosis involves microscopic examination or cultures. Neonatal thrush is treated with oral nystatin, while older children use clotrimazole troches. Immunocompromised patients may require fluconazole or itraconazole. Esophagitis is managed with oral or intravenous fluconazole, itraconazole, or other antifungals. Nurses must educate families on the contagious nature of ringworm, emphasizing hygiene and avoiding shared items. Pets and household items should be checked for infection. Topical shampoos like 2% ketoconazole reduce spread, complementing oral antifungals such as grisafulvin, which require adherence and monitoring. Alternatives include terbinafine, itraconazole, and fluconazole. Dermatitis is a broad term for skin inflammation, often resulting in redness, swelling, and itching. It can be triggered by various factors, including allergens, irritants, and genetic predispositions. Effective management involves identifying and avoiding triggers, using topical treatments like corticosteroids, and maintaining skin hydration. Understanding the specific type of dermatitis is crucial for targeted treatment and prevention strategies. Contact dermatitis is an inflammatory skin reaction to chemicals causing irritation or hypersensitivity. It appears on exposed areas with sharp borders, redness, blisters, and itching. Causes include primary irritants and sensitizers such as plants, metals, fabrics, and cosmetics. The main treatment goal is to prevent further exposure, allowing the skin to heal. Nurses play a crucial role in identifying contact dermatitis during assessments. Localized rashes may indicate limited exposure, such as from mascara or wool, while generalized rashes often stem from soaps or lotions. Nurses can guide families on prevention, but persistent or infected lesions necessitate medical evaluation. Now let's move on to skin lesions. These are any visible changes in the skin's appearance or texture. Lesions may be primary, such as blisters or papules, or secondary, which develop later, like crusts or scars. Our nursing role includes careful inspection and documentation of the lesion's features, maintaining skin hygiene, applying prescribed medications, and educating patients about preventing infection and protecting their skin. Skin lesions in children can result from irritants, hereditary factors, allergens, or systemic diseases like varicella and lupus. Age influences lesion types. Infants may have birthmarks, school-age children tinea, and adolescents acne. Social and environmental factors such as smoke exposure and food allergies notably increase atopy risk, affecting 20% of United States children. Understanding the distribution, size, location, and morphology of skin lesions is crucial for diagnosis. Nurses must be familiar with terms like erythema, ecchymoses, and petechiae for precise documentation. Primary lesions include macules, papules, and vesicles, while secondary lesions result from alterations. Recognizing distribution patterns and configurations aids in identifying specific conditions. Laboratory studies are crucial when skin issues suggest systemic diseases like collagen or immunodeficiency disorders. Key diagnostics include microscopy, cultures, scrapings, biopsy, cytology, patch testing, and woodlight exams. Additional tests such as allergy testing, complete blood count, CBC, and erythrocyte sedimentation rate, ESR, are employed as needed. Now we'll talk about wounds. A wound is simply a break in the skin's integrity. It can be intentional, like in surgery, or unintentional, like an injury. Wounds heal through several stages, starting with clot formation, followed by inflammation, granulation, and scar formation. As nurses, our main responsibilities are to maintain sterile wound care, assess for infection, manage pain, and promote healing through proper nutrition and patient education. Wounds disrupt the skin, initiating repair. They are acute, healing in 2 to 3 weeks, or chronic, with delayed healing. Factors like poor perfusion, malnutrition, and infection hinder healing. In children, most wounds are acute and preventable from becoming chronic with proper care. Wounds are also classified as superficial, partial thickness, full thickness, and complex, similar to burns. Acute wounds include abrasions, avulsions, lacerations, incisions, penetrating wounds, and punctures. Abrasions involve superficial skin removal, while avulsions forcibly extract tissue. Lacerations are jagged cuts, and incisions are clean cuts by sharp objects. Penetrating wounds disrupt skin into deeper tissues, and punctures have small openings relative to depth. Nursing management emphasizes removing factors that impede natural healing. In pediatrics, triggers like soaps, lotions, and environmental elements can exacerbate conditions. Dermatitis may worsen with home remedies, poor nutrition, or smoke exposure. Key goals include preventing further damage, eliminating causes, reducing complications, and relieving discomfort. Dressings play a crucial role in wound management. Gauze or sponges are used externally, while hydrophilic dressings maintain moisture. Occlusive dressings create a barrier, hydrogel dressings provide hydration, and porcine dressings aid in healing. Each type serves a specific purpose, enhancing recovery by protecting the wound and promoting optimal healing conditions. Nursing care management. Accurate skin assessment involves inspecting and palpating for changes in color, shape, size, character, and lesion distribution. Use precise terminology as multiple lesion types may coexist. Evaluate wounds for tissue damage depth, healing evidence, and infection signs like drainage, warmth, and odor. Palpate the skin to evaluate temperature, moisture, texture, elasticity, and edema. Determine if these findings are localized or generalized. Gather a detailed history of illness, wounds, and symptoms. Older children can describe triggers and treatments, while younger children rely on behavior and caregiver reports. Review medical history, allergies, and medications for diagnostic clues. The primary goals in nursing care management include ensuring patient comfort, preventing infections, and limiting the spread of skin disorders. Chronic conditions may necessitate specific medications or treatments. Isolation is generally unnecessary unless there's a risk of secondary infection or highly contagious conditions like chickenpox or lice, where exposure should be prevented until healing or treatment is complete. Thank you for your attention. If you have any questions, feel free to ask. We appreciate your engagement and hope this presentation has been informative.